thank you all for joining our session here today. And what an awesome meeting. Thank you so much, Justin, for lecturing with me. I always look forward to doing that. We're really going to take on an important topic. Such an important thing that we are faced with every day in treating glaucoma and ocular surface disease is drops and dry eye, quality of life considerations. And I love that we're going to be talking a little bit about quality of life. As you all know, Justin Schweitzer is a glaucoma expert, doctor of optometry, who has really been on the forefront of glaucoma care. And Justin and I are in similar clinical practices where we see a lot of perisurgical cases, glaucoma, and ocular surface disease. And so thank you, Justin, for doing this talk with me.
Excited to do it with you. Again, I feel like we've done a couple of these together lately, and always an honor. And thanks for being a big part of Eyes on Glaucoma this year, Ahmad.
You bet. It's my honor and my privilege. So, I'll just say one more thing about the reason I really love learning and lecturing with you. It's pretty clear that this is something that's a part of your daily routine, and you just speak so, from experience about all of this. So I really thank you for doing that. So these are our disclosures, everyone. So, when I kind of was wrapping my head around kind of the approach for talking about this, I really learned a lot about how we should be addressing probably something that might fly under the radar a little bit when we treat comorbid glaucoma and ocular surface disease. And so quality-related, health-related quality of life is such an important part of what we are doing, especially in our glaucoma patients, because it has so many implications in our success of treating the condition. So these are some of the things that are probably going to come up during the talk, but we're also probably going to have some things that are not on the slide that are also going to come up. Some of the tools that we now have to improve the quality of life of our glaucoma patients, and the kind of organizing our approach and how to treat a pretty complex set of variables that are in glaucoma and ocular surface disease. And then, Justin and I will kind of suggest an approach, at kind of ultimately providing better quality of life for our patients with both of these diseases. So without any further ado, let's really just sort of dive into health-related quality of life for our patients. I mean, this is something that we probably don't have as our first thing that we talk about in the majority of our, patient visits. But there's really, in my kind of reading about this, there are two really important studies that I read through, and it really helped me understand that when patients think about health-related quality of life, it really is their impression of their physical, mental, and social well-being. And sort of the diagnosis of glaucoma, of course, is sometimes can be very stressful for these patients that might be dealing with multiple other situations in their life that are affecting their quality of life. So there are a whole bunch of different variables. And it's important for us as glaucoma specialists to think about what are the patient's goals, where are they with their independence, their level of independence, because that directly relates to our treatment plan. The CDC describes it really kind of focused on, in these clinical studies they referenced, that's the patient's perception of their physical and mental well-being. And that is really how they assess their health. And that really struck me, this last kind of statement on this slide really struck me when I read these clinical studies, because it's the most powerful indicator of mortality and morbidity, more than objective measures of health. And so this is something we really have to be paying attention to, because as you know, in glaucoma, we are, adding one more thing to many patients that might be struggling with multiple systemic conditions, especially in that age group. And we're kind of used to doing that as we treat ocular surface disease. This is a questionnaire that we think, there are a whole bunch of them out there. But the one thing I love about this questionnaire is that it helps us understand that the symptoms that our patients might be going through in treating glaucoma and ocular surface disease, these have a direct implication in their quality of life as it relates to specific activities they're doing during the day. They're kind of specific things that they're doing. So Justin, I wanted to kind of ask you, this is probably especially in glaucoma and ocular surface disease, there are a lot of challenges in getting patients to be compliant. I think one of the most important things is how we connect with our patients and what words do we use to get them to be compliant, which is absolutely critical for the best outcome and therefore the quality of life. So what is that discussion like with your patients when you're kind of considering quality of life implications and you starting them or having them use multiple medications?
Yeah, no, it's a really good question. I think the first thing is you got to take time to allow them and you explain to them what the disease is and what the consequences of the disease are. Because many of these patients, as you've kind of already mentioned, don't really know they have it. The visual field defect or early glaucoma, they're not aware of it. They don't know that they're having visual problems. And now you're going to be prescribing a medication or recommending a procedure, whatever it may be, to treat something that they don't think they have a major issue with. So I think the first step is making them understand the consequences of the disease if they don't do the treatments. And I think the second piece of it, which you're going to talk a lot about here, and we're going to get into more, is always reminding yourself that you don't want to make the burden of whatever they're going to go through overwhelming for them. And that may mean a patient can't take a drop, and we need to think of a surgical means. Or it's a patient that can take one drop, but they're not someone that's going to be able to be compliant on 2 drops or 3 drops. And so always keeping that in the back of our mind, that reading your patient, having a verbal conversation with them about what can I do to make sure that they take the drop, and what are they capable of doing to take the drop, or do they need to do something surgical in regards to it?
That's absolutely brilliant. I mean, the way you framed it as far as what are they capable of is really important. I mean, I've had those patients that have added drop number 3, had them come back for their follow-up, and they're tolerating it okay. The follow-up after that, they come in not using all of the medications I prescribed, and the visual field is reflecting that disease has gotten worse. So we really have to be, in tune with that. And the main reason for that, of course, is it directly affects their compliance. And so really thinking about quality of life and their perception of that is important. And in fact, I think that after doing some of the research that I did for this talk, I will be using some questionnaire to help me understand what is the person's interpretation of where they're at with their overall health, because it's so important. And for us, it might be that, we need to be sometimes a little bit maybe aggressive with some patients. I've also been on the other side of things where a patient is, newly diagnosed and they don't have significant symptoms, but they really just don't want to use the drop. So it's important to, just like you said, help them understand this is a problem that can lead to significant vision loss. And so, getting them to comply, and there's such a whole big continuum of patients that are in that, early stages of it and on the later stages of it. So there are issues and kind of challenges on both ends of those things. In these clinical studies, they really identified several factors that are kind of big red flags as far as the patients that had poor quality of life. And these are progression, obviously, of the disease state, the female sex, older age, lower education and economic status, and unmarried, status. So some of these things are actually a little bit tough to really tease out in the number of minutes that we have to spend with our patients, but these are red flags for me, just like our glaucoma risk factors. And just like you said earlier, Justin, these patients, sometimes they don't really have any idea that they have glaucoma, but psychologically having that diagnosis land on you can be, really significant for these patients. And we know that assessing these things as we go along will have a better impact on we're in it for the long game. As, Paul Singh said, a few days ago, that, if you wait long enough, it's gonna get you. So we have to really think about this in the long term. So I really think that, as you see on this slide, if there is one part of the presentation today, as far as visually, that really connects with you guys, I really want you to kind of try to, make it this slide right here, because as I think about progression of glaucoma, really our goal is to try to get those patients, of course, on the left-hand side of your slide there and away from functional impairment. And of course, we know that there is comorbid ocular surface disease in the majority of our glaucoma patients. And I think that if you're really good at this, you can try to keep your patients at level 2 severity in ocular surface disease or better. Or when they slip into that 3 or 4, you're anticipating some of these things and you're ready to escalate treatment so you can get them back into that level 2. So I think being on the left side of this slide really is kind of my goal as I think of approaching how we can simultaneously treat these conditions. I put this in here because it's really important for us to think about one of the main risk factors I want all of my students and all of, and I remind myself of is pachymetry. Is really important for us to think of pachymetry on our glaucoma patients, and some of these folks after refractive surgery. It can be really tough to try and understand what their target pressures should be. So that's really, of course, really relevant because that will have big implications as to their overall, treatment and success of their treatment. So I want to talk a little bit now about kind of the then and now. This is Tom Samuelson's beautiful artistry here. So we can see that earlier, we used to kind of think of glaucoma as how we can describe the nerve and how that visual field looks. And that's really kind of the main thing that we were really monitoring over time. But of course, now we have so many great tools that very precisely are able to measure the nerve fiber layer, retinal ganglion cell layer thickness, the optic nerve anatomy, corneal hysteresis, OTCA, ocular perfusion. There are a lot of tools that we have now on the diagnostic end of things, and that has really spurred a lot of innovation. So now we don't have just drops, of course, in incisional surgery, but there's this great, really, useful space, the MIGS space. And this is not going to be kind of a big lecture about, which MIGS procedure to do when and things like that. But as it pertains to quality of life of our patients, it's really important for us to be thinking about this group of treatments as, something that we should be thinking about earlier and earlier when we're diagnosing and treating these patients. I talked earlier about kind of ocular surface disease continuum. And this is from one of the main studies that we have at our disposal. What I love about this is that it's not only the tear film and the corneal epithelium that we really should be thinking about when it comes about when we talk about ocular surface, but the conjunctival health. So it's such an important part not to miss in our OSD evaluation of our OSD patients when they have comorbid glaucoma, because the conjunctiva is a really important has important implications, especially if they need to progress to have incisional surgery or glaucoma, so or trabeculectomy. So it's really important to really kind of zero in on how much conjunctival injection there is, and of course how that relates to the number of medications that we're using. And again, using some of these MIGS procedures early on can really help these patients in case they need to have glaucoma and more invasive glaucoma surgery. So Justin, one of the things that I'm challenged with, of course, sometimes is trying to figure out, there's glaucoma, there's ocular surface disease. I know that we have a great number of tools that we can use to lower the pressure and improve ocular health. This is a neat study by Dr. Alice Apotropoulos and colleagues that looked at the gland volume as it relates to patients that had thermal pulsation. And this was a technology that was used. It's not going to be really available to us to use this level of imaging in the clinical setting yet. But the idea here is that patients get better when they have thermal pulsation. Now, how do you, kind of approach that in patients with glaucoma? What is the appropriate time to escalate OSD treatment in a patient that we know these things are not happening in a vacuum and they affect each other? So when do you kind of talk about, escalating ocular surface disease in your glaucoma patients?
Earlier is better. I mean, the sooner we can catch it, the better. I'd prefer it not to be like the top left picture, looking at that gland there, or those glands. I'd love it for it to be earlier than that. And so earlier is better. And I think, in general, with glaucoma treatment, I think we've all gotten to the point now where we really should be thinking with an interventional mindset. And what that really means is intervening earlier in the disease process, meaning intervening earlier in the glaucoma disease process. You already mentioned MIGS in mild to moderate glaucoma patients. Let's intervene earlier because we have safer procedures to do that. And also intervening early in the ocular surface disease process. We have ways to reduce the medication burden with SLT, MIGS, drug delivery. And so there's not a reason anymore to allow patients to get to those advanced stages, whether we're talking glaucoma progression or ocular surface disease progression in that specific patient population. We have the tools to be able to at least intervene earlier. And so that interventional mindset is so important.
I totally agree. And, I think that's how we can kind of stay on that left-hand side of the disease progression of both glaucoma and ocular surface disease. And so, I mean, it really should be the standard of care really we know that a lot of our ocular surface disease problems really have meibomian gland function as a part of the problem. It's a multifaceted problem. There are a lot of moving variables, and therefore there should be a lot of pieces that go into an adequate treatment plan. But really knowing that we have meibomian gland dysfunction as a hallmark of a lot of our ocular surface cases, I think really, offering these treatments early on, just like you said, is really important for us. The challenge I have sometimes is if a patient is a little bit overwhelmed with needing to do a bunch of things, is at what time do I do that and not have them just kind of become a little bit sort of, frankly, overwhelmed with some of the things that we need to be doing simultaneously. So I try to, make sure that they have a good family support. They have, someone that can help them if they're, struggling with some of these things, but absolutely key to intervene on both ends earlier on. I really wanted to kind of just take a minute to talk about how important the tear film is as it relates to all of these drops that we need to use to lower the pressure in our glaucoma patients. This was a really neat study that looked at experts all over the world that have really, kind of, I think of them as dedicated their whole life to really researching ocular surface disease, not just the DEWS-2 report, but this is kind of a group of experts from all over the world. And one of the things that really struck me in reading this is that they thought of tear film dynamics and instability of the tear film as really a primary factor in identifying or the definition of dry eye disease. And you can see there the DEWS-2 report was really the only one that was sort of an outlier there, but just really stresses the importance of paying close attention to that tear film when we're asking patients to be using drops that we need to lower their pressure. So the global consensus really is that tear film is a critical part of how we assess these patients. So the other thing is, this was again in that main study, they really, kind of explained, different signs that the tear film might be giving us different clues as to what's happening with that patient's ocular surface and how much trouble that the patient's ocular surface might be in. So on that column on the left-hand side, one thing they talked about was an area break where and we've seen all of these patients where they open their eyes and all of a sudden there's no tear film there. It's just, really more severe aqueous deficiency dry eye. And then on the bottom there, they called this kind of a spot break where the patient opens their eyes and you get this pattern that just looks really, like the one on your, the lower image there. And I see that frequently in clinic. And they kind of talked about that more so probably with being indicative as decreased goblet cell density and decreased wettability dry eye. So, and then other examples of a line break where the patient has on the upward movement of the fluorescein, they have this line break that you can see in the middle column there on the top. And then something called a dimple break that sometimes might happen with patients that have some imperfections of the surface and maybe have EBMD in that area. That top image there on the central column is, of course, that patient probably has an incomplete blink where that pattern of PEK is on the bottom. So I've used this image here is really important for me to really zero in on. I should probably talk to this patient about their blink. This patient might have, severe aqueous deficiency. This patient probably has decreased goblet cell density. So what the tear film is telling us about the patient can also be really important. And of course, this again is really important for their ability to be able to tolerate these medications. We know that, vision loss and vision impairment is preceded by, by structural and functional changes in glaucoma. The same thing happens, of course, in ocular surface disease. So as we were talking earlier about the importance of doing some really, careful meibomian gland assessment, some idea of the viability and the anatomy of the eyelid in the meibomian glands is really important because we typically see more changes as this, if the patient there that's on your right-hand side has a lot of, meibomian gland atrophy, most of those patients, it's really tough for them to tolerate some of these, medications. And so this is why it's critical. And we've all been in these situations where we prescribe certain medications. the patient comes back in saying, yeah, I tried that drop. It really stung and bothered me. This is going to be more common in these patients that have, so, meibomian gland dysfunction. So really understanding that there are some structural problems that happen before that corneal epithelium and the conjunctiva is really beat up is important. So one of the main things I want to kind of stress here is that we can think of glaucoma as this complex and stubborn and persistent disease with real bad quality of life implications. The same thing happens in ocular surface disease. So sometimes it can be super scary. You've got a patient that you got to think about their glaucoma getting worse, and their corneal epithelium just looks like this. And it's just like that spot, I just cannot get it to heal. But don't worry about this, guys. There are a lot of things that we can do, and we're going to treat this like real doctors. And we're going to stare this thing down, and we're going to treat it like real doctors. So this is just a case of mine, a patient that has really tough ocular surface disease, has been hospitalized for suicidal ideation. So this could be a real big problem. And again, as it pertains to quality of life, this is really important for, these patients who've been all over the world. So ocular surface disease can be really challenging and really tough, but understanding some basic principles, really two main buckets in ocular surface disease, inflammation and obstruction. So we know there are a lot of moving pieces, but there's two main things that I find to be really important to zero in on. And in every treatment plan, I think to myself, what am I doing for these two main things? So Justin, where it's a bit of a balancing act. We know that conjunctival epithelium, which is progressively getting more inflamed in our glaucoma patients, is something that we have to control when it's appropriate to use steroid eye drops. Of course, there are some implications when it comes to using steroids in our glaucoma patients as well. So what are some of the pearls that you can give us as to kind of managing these two things? It's kind of it's a delicate balancing act in some of these patients.
Yeah, it really is. But it is important. And obviously if it's a patient that is a steroid responder or steroid-induced glaucoma, I'm not going to utilize a steroid. But we have the so-called soft steroids that many of us use that, yes, there can be some IOP elevation there, but I'm very comfortable in my glaucoma patient population to use those for a 2-week or 4-week basis to try to really get the inflammation under control. And then the other thing I think about is, well, what are they being managed with? Are they on 3 medications? Are they on 2 medications? Are there options for me to reduce the medication burden? Because less medications will typically equal less inflammation. We have drug delivery we consider SLT, we consider MIGS procedure. Can we figure out a way to maybe not eliminate the medications, reduce the burden? So for me, I think of it 2 different ways. Number one, decrease the inflammation with those traditional softer steroids, as long as they're not a steroid responder. And 2, how do I reduce that medication burden? And we can usually make an impact on the ocular surface in those regards.
This is a clinical study that really thought, zeroed in on goblet cell density. This is Victor Perez and Stephen Flugfelder. And again, these ocular surface disease has innate and adaptive immunological changes that with time can start to, again, show decrease in goblet cell density, which is really important for our glaucoma patients. This is a really, I love confocal microscopy images. This is, you can guess that the top row here is showing goblet cell density in sterile saline, a confocal microscopy in vivo images of goblet cell density with confocal microscopy on sterile saline. And then the bottom, of course, is showing BAK 0.02%. So we know that patients that need to use preserved medications can have decreased goblet cell density. This is a patient of mine as it pertains again to drops and how this is really important for the quality of life of our patients. This is a patient who's had multiple glaucoma surgeries and has a corneal transplant, has had a bleb revision, a tube, patch graft revision, and micropulse ×2. This is her better seeing eye. She became neurotrophic over time. So sometimes when we think about eye drops, yes, we need those drops and we need to be using them to control the pressure. On the other end of things, make sure that we are using eye drops that really are, sort of at the high enough level to treat the level of ocular surface compromise as well. And then the other thing to keep in mind is that sometimes patients with severe ocular surface disease issues will need multiple surgeries that end up causing or kind of contributing to their pressures going up and developing glaucoma, as is the case with Stevens-Johnson's and chemical injury, limbal stem cell deficiency. This is a patient of mine who kind of I wanted to, use this, case example. Justin said earlier, one of the things that we can do for these patients is what other options are there? This is a great example of a case where we do not have much room for error in patients that have severe ocular surface disease and severe glaucoma. This is a monocular patient, young guy, had super high pressure, Stevens-Johnson syndrome, and this left eye is NLP, scleral thinning, failed corneal transplant. This is his right eye, 50 years old, and he's gone from 20/30 vision in his better seeing eye to 20/80, and I'm seeing him in clinic for basically kind of irritation and a flare-up. And the reason I uncovered the reason why he was having that is he has a flare-up because he has a sensitivity to rhodoprednol, which was actually identified earlier in our chart. So we never ever want to lose track of something that we've discovered about our patients. If we know that their body doesn't like a certain chemical, we really have a kind of a not much room for error in some of these patients. So I, basically restarted him on his steroid that he was comfortable with, and then discontinued one of the medications and trying to heal the ocular surface, and then going to see what happens with him, basically on follow-up. So just wanted to share this case because it's really important for us to, once we've identified that something can flare up ocular surface disease, that can have big implications for their glaucoma. These are some of the medications that I think are really appropriate for us to be thinking about in our patients that might have more severe level ocular surface disease, autologous serum, PRP. I also like to use amniotic membrane derived cytokine eye drops, but we should be thinking about these as good options for our patients that are on the more severe end of the spectrum. And then sometimes it's not just neatly fitting glaucoma and evaporative dry eye. Sometimes there's a bunch of other things going on, like allergies, immune, conditions, severe rheumatoid arthritis or lupus, and ectropion. So really paying close attention to that lid anatomy is really important. And of course, tear film instability. So these are all things that we can really make sure we don't lose track of when we're managing our glaucoma and ocular surface patients, is that lid position. And then this was a neat little study in Journal of Ophthalmology that was an example of drug-induced ectropion. So I didn't, it was like, oh, was this really a thing? But it can happen in some patients. So being, kind of investigating those things is really important. As it pertains to, kind of improving the quality of life of our patients and getting the best outcomes, pressure is one of those things that, we know that some patients with high pressures will never really have, moderately high pressures will never have glaucoma, and we have patients that have low pressures that have significant and progressive glaucoma. But it is the one thing that we can still modify. We have to use that with eye drops, and it's important for us to look at target pressures. I put this in here because I think really this is sort of an older way of doing things. I think it's important for us to be thinking about some kind of a protocol for choosing your target pressure. But I would say that you don't really have to follow, this approach. And on the bottom there, I just want to highlight this again. Sometimes it takes for us to move as a group and really think about a new paradigm of looking at things. It takes some time, but really I want to, I put this in here because it's important for us to kind of move away from either drops are going to work to control glaucoma, or then we just need to use trabeculectomy, which is, what was in this clinical study. So, but Justin, just as an overall approach to, getting the best results for our glaucoma patients, I think the standard of care really should be, we should have a target pressure somewhere identified in our chart. What's your general approach? And in addition to what we see here on this slide, what are some of the things that you think, okay, and if you're thinking about a target pressure, do not miss this variable or that variable?
Yeah, I typically put a target range or less than this, so mid-teens or low 20s. But I think it matters a lot where the patient started at, right? If we have a patient that has a pressure of 30 at baseline, do we really need that patient to have a target pressure of 10 or 11? I think it matters on the level of the glaucoma. But a lot of times, if you can get a 30% reduction in initial therapy, that should be your initial target kind of pressure. We know that that's kind of the magic number, 30% or so. If we get that, you're going to be in a pretty good spot. And then you have to adjust your target pressure, as you already mentioned, based on what's happening with the visual field, the OCT. So I try not to get caught up in IOP as well. I think IOP matters and it's what we have to lower, but we have to think about where the patient came from. Now, on the other side of things, say the patient's highest pressure was 18 and it's more of a low tension or normal tension glaucoma patient. Even just getting a 20% reduction may be enough to slow things down. That comes from our glaucoma landmark studies. We don't necessarily need 30, 35%. So we have to, use a mix of things, our glaucoma landmark studies, where the patient's highest pressure was. But in overall amount, I think you do have to somewhere in the chart either do a target range or a target pressure so that you kind of have a basis of where you need to go for in the future.
Perfect. Absolutely. I couldn't agree more. And that really helps me to kind of communicate that with the patient. And they feel like, oh, this guy really has, a goal that he's working towards, understanding where we were, that Tmax, and just making sure that wasn't around like right after cataract surgery where they might have had retained viscoelastic or something like that. And then as you, really, really nicely said, it really depends on how tenuous is that nerve. What level of severity are we dealing with? But I completely agree that using a target pressure has been really helpful in getting the best outcomes. So we know, again, this is not kind of a talk about, this drug does this in glaucoma, but or the fact that, just that we know that preservatives are really going to, at some point cause some corneal epitheliopathy. But I also wanted to point out here in this slide that a lot of these medications do have different variable levels of BAK and different preservatives. There are a lot of clinical studies that have looked at the implications of that and the success rate of the trabeculectomy. So we know that there's a correlation between BAK use and trabeculectomy failure. This is a neat study here. This is actually an NK neurotrophic keratopathy study that looked at basically causing an epithelial defect. 24 hours later, the bottom on your left-hand side there shows that the epithelium heals really nicely compared to another sample where the corneal epithelium, there was an abrasion that was caused, and then the bottom image there shows that it didn't really heal at all in the sample where there's PAK that was being used. And so this again talks about how fragile that corneal epithelium is and how important it is for us to be really thinking about long-term use of BAK for this long-term, condition. But it also has been, other clinical studies here in the Journal of Glaucoma, it looked at BAK as actually being a big risk factor in TRAB failure, independent of the number of drops being used. So again, we need to use eye drops to control glaucoma, but really when looking at these studies, we have to be really examining, are there better options for these patients, including the mixed category that Justin was just really talking about. So we know, in addition to that, we know that when we increase the number of drops, that really it correlates very well with more patient symptoms. And it's very, logical that happens. And we know that one of the things that can be another good solution to this is non-preserved glaucoma medications. And so that was going to be the next thing I was basically gonna really offer that patient I had in my earlier examples to see if we can use some non-preserved glaucoma medications to keep that inflammation down and keep the pressure in our target zone. As we know, there are a whole bunch of challenges with drops, and it's not a perfect system. This is a Journal of Ophthalmology's kind of a study that looked at all the different factors that go into using drops successfully. It has to do with patient compliance, their dexterity, and then the formulation itself. All of these drops are very different, the drop size. And then we just know that the path that these drops take once we put them in the eye, there's very little of that's actually getting absorbed by the eye. And there's a big range here, but much more of it gets absorbed systemically than by the eye. So less than 5% of the medication is actually getting into the eye. So it's a really sort of an imperfect system, but we know it lowers the pressure for our glaucoma patients where it's important for us to lower pressure. So in these patients where we have a lot of different options, this is always going to be an important part of our toolbox, but we really should go into this understanding that not all of the drop is getting in the eye. Sometimes patients I wonder when I look at this and think to myself, less than 5% is getting in the eye on the perfect scenario. Well, what if this patient really doesn't love that drop and is tearing a lot there are a whole bunch of other, variables here. So in addition to using these drops, again, what are some of the other options that we have at our disposal? And then there's this sort of the, discussion about generics and branded. So Justin, what is your discussion again with your patients about, generic medications versus branded, and what you think is going to be more efficacious and kind of a better way to go?
Yeah, I really advocate for branded medication. And this study that you have in front of me right here really kind of turned me on to saying, boy, I should think about branded medications more often than generics. And really what the study showed is that when they expose some generic medications to a few different temperatures, that the active ingredient, the preservative in the generic medication was affected by that. And the branded medication, you didn't have that effect. And so you didn't have an effect on the active ingredient, you didn't have an effect on the preservative, and you didn't get particulate matter as well, which is essentially pollution in the bottle. That happened with generic, didn't happen in branded. So I advocate for branded. I think pharmaceutical companies have done a great job with giving us access to be able to get branded medications. Not all my patients are on branded, but I advocate as much as I can for branded in my practice.
Awesome. Yep. And this is the I think about the guy that's, comes in with, 4 or 5, or two bottles in his pocket. And I think to myself, that's not at room temperature. Or the guy that like leaves his medication in his truck or something like that. When it's switched here, sometimes medications will get switched without me ever knowing. Once I know that information, I like to have them at least come back and check their pressure, because sometimes it's not going to be as effective. I put this slide, this is some of my personal, sort of things that I think about as far as tolerance and compliance. And I put this image in here because it's a beautiful picture of an eye. It's a beautiful picture of an eye drop, but it's not in the right trajectory. So sometimes patients really feel like they're getting their drops in, but it's just not making it into the eye, especially those patients that might be in a nursing home or, kind of need a lot of help. I've had the experience of working in some nursing homes, and even when they have staff that is helping them with drops, I kind of think about, really, is that drop getting in or not? But one of the most devastating things that I've really struggled with and kind of always have on my radar is disease knowledge. So if our patients, like Justin was saying earlier, it's really important for the patient to understand the potential severity level on their vision if we start to not control the pressure very well. So I try to really make sure that I'm using a lot of time in my every visit, so that the patient understands that this is something that could have significant impacts on the vision if we're not treating it appropriately. And so those high velocity progressors, sometimes if they don't really connect with you on this potential, for this thing to get out of control, they can really suffer some vision loss. So it's important for us to really, make that an important part of our discussion with our patients. So some of the things that we think about when we're thinking about escalating treatment, we really should be thinking about glaucoma severity level, and at the same time, OSD severity level, risk factors. Can this patient even get the drop? Because none of this really matters if it's too costly for them. But one of the things that I think is really critical and important for us to think about is about 60% of these patients that are treated for glaucoma will have some OSD symptoms. And then we sort of, have these patients, okay, the target pressure is beautiful. We're in that range. The visual field is non-progressive, but this is what our patient looks like. Well, there must be some better options for our patients. So these are the things we really have to think about when we sort of think about this dual dilemma of glaucoma. Dr. Lisa Nijam has spoken very eloquently about this, and many of our colleagues. These patients that have a, kind of glaucoma and ocular surface disease might also be, struggling through other health issues and things where they need, polypharmacy just to control their glaucoma and ocular surface disease. And these patients are more likely to have ocular surface problems. So Justin, what should we be thinking about right now is, what is your criteria for a well-controlled glaucoma patient in now 2022?
I mean, I think the well-controlled glaucoma patient now is someone that's on less medications than they were before. So that reduction of the burden of medication. So rarely do I ever go above 2 medications anymore. It's 1 or 2. And if I'm going to a third, I'm figuring something else out. And then I'm always analyzing the glands. I'm always analyzing the corneal surface for staining. And I'm going to treat those things if I see that. And so for me, they're a non-progressing patient on 2 or less medications, and I'm doing everything I can to preserve the glands and to preserve the cornea from that staining portion. And that to me is a well-controlled patient.
Awesome. So here's kind of some humble suggestions as to how we get there. We kind of talked about this earlier. It's really important to think about this amazing innovation in intracameral injections, SLT, MIGS, all of these other, things that we now have out of this amazing, a lot of innovation in the MIGS space. Every glaucoma patient should have an ocular surface disease evaluation. So if you're super focused on glaucoma and you miss that part of it, well, it's a part of your glaucoma therapy. These patients might become non-compliant because of something that you might have missed. So everyone really should have a careful OSD evaluation. Patients that need to have intermittent use of steroid eye drops should be seen as glaucoma suspects. So a patient that I've seen for many, many years with ocular surface disease that's had a pressure of 12 or 15, that's a 0.3 nerve, I always I'm suspicious of that, and it's important to be doing optic nerve at OCT imaging on those long-term OSD patients, because sometimes we know that they flare up and it's appropriate to use steroids once in a while. So don't lose track of those patients as well. And of course, we're going to be monitoring these things simultaneously, and asking the patient about their self-perceived health quality of life is really important. So I'm going to make kind of one last kind of statement here. We're really, I think, at a time where we're really succeeding in slowing down the progression of glaucoma. I think most of our glaucoma surgeons would say, I'm doing a lot less trabeculectomies now. And this is happening at a time where we're actually doing we're able to preserve the ocular surface at the same time as really slowing down the number of patients, the progression of glaucoma, and the number of patients that end up in that functional, impairment. So it's a really exciting time. Justin, I just want to thank you again for giving this, this nice talk with us. I thank all of you for being, with us at this talk, and Justin for doing this one with me.
Ahmad, great. Thanks so much. Thanks for all you do for our profession and for your patients. And just love the way that you handle yourself clinically and through this lecture, just dropping knowledge with all these different studies. So thank you for having me. It was an honor.
My pleasure, buddy.
Well, hey, Ahmad, how are you? Great to see you. And man, that was a lot of fun doing that lecture with you. And for everyone that listened to that lecture, Ahmad kind of brought me in last minute. We'd had a discussion. We've done these together before. And I was so grateful. You said, hey, why don't you jump on with me and let's do this one together. Let's tag team it. Man, I had a great time. So thanks for making me the late addition to your talk, essentially.
Always a really important addition, Justin. So I really appreciated the opportunity to do the talk, and thanks for doing it.
Well, this stuff is near and dear to our heart. You and I did a talk together, Eyes on Dry Eye, which was earlier this year, talking about really ocular surface disease and glaucoma. This one, we were focused a little bit on that, but also on just quality of life issues in our glaucoma patients in general. And so really the question that I want to ask you to kind of kick this off is, besides ocular surface disease, what are the other quality of life things we need to consider with our glaucoma patients?
I really love our discussion earlier about, especially these patients that are being first diagnosed with glaucoma, being told that they have something that is potentially blinding, that we know is chronic, and is something that can be really, negatively affecting their quality of life. For us, we think this patient has a tiny nasal step. They're not going to really have any significant impact. So we might not be really focused on how impactful this new diagnosis is. But for the patient walking out of your exam room, it might be a pretty tough thing for them to really wrap their minds around. And we know from a lot of clinical studies that have looked at their perception of their health and where their position is and all the salient factors of their environment is really important for us as it pertains to the success of our glaucoma treatments. So I try to think about, how do I, put these in terms that the patient really, that are more relevant for our patients. So, there are kind of 4 things that patients really are, tell me that are really important for them as it pertains to their vision. I want to be able to drive safely. I'm an avid reader. I want to read. I want to feel safe in my environment. And in a lot of my patients, we kind of save, and work really hard to retire. And at this stage in their life, they want to do traveling. And so they want to be able to get out there and enjoy traveling. So those main things, I try to think about those and then put it in terms that the patients really understand. Visual fields and visual acuity are really a great indicators for us on should we be escalating treatment or monitoring, but they're not very good predictors of how the patient is functioning outside of the exam room. So, I try to ask the patient, are you bumping into things recently? When you drop something, does it take you a long time to pick it up? Are you, is your balance a little bit, is it okay? There are clinical studies that have identified that patients with visual field defects that are more inferior have more falls. And so trying to be a little bit more mindful of that and put it in terms that the patient really understands on their daily operations or kind of their day-to-day functioning.
It's so important. And I will be the first to admit, I forget that quite often and try to keep it front of mind, but you have so much going on and you're seeing so many patients a day and you're worried about preventing that patient from going blind. But those things are so important because that's really what's affecting them out in the real world. And we don't see that. And so sometimes it takes a wake up call, having a conversation with a good friend like you, talk like this to remind myself and probably all our colleagues on this lecture today that we need to have that discussion. So I want to ask you another question. Again, we've been focused on some other quality of life issues, but still one of the biggest ones we deal with is ocular surface disease. And, you're in a practice, I'm in a practice where we have a lot of tools to manage ocular surface disease from a technology standpoint. But I really want to ask you, what do you really need simply to get started with managing, whether it be a normal patient that has dry eye, but doesn't have glaucoma, or a patient that does have glaucoma? What tools do you need in the toolbox to start managing those patients?
I would really just encourage everyone to be very laser focused on two main things. During that study, there was one slide that really kind of looked at the nuances of your tear film. So being kind of a tear film connoisseur, you really need to have a slit lamp and sodium fluorescein. And as you reminded me just a moment ago, Justin, and thank you for reminding me, pushing on the lids to see what's that quality of that oil that's coming out. So really focusing on those two main buckets, you can quickly identify if that patient is really struggling with tolerance because of their tear film and their ocular surface disease. So you don't really need to have all the bells and whistles out there. If you have, again, just a really a higher level understanding really of the tear film dynamics and how critical it is to look at that meibomian gland quality, the secretion quality is really the main thing.
Yeah, and you said it brilliantly in the lecture. How you analyze the tear film and how the tear film looks to you, and I love that. I actually commented on that because I just thought that was so impressive how much of a master you are in that, and it was very helpful. Last question for you. We have about 2-3 minutes left. In regards to the collaborative care piece of ocular surface disease, what is your suggestion around communicating with our ophthalmology colleagues that are doing surgical procedures? Specifically, we're talking glaucoma, and communicating the expertise of us dealing with the ocular surface and preparing that ocular surface before we make that referral, or vice versa, them referring a patient to us to treat the ocular surface because they spend a majority of their time in the operating room. Would love to hear your thoughts and comments on that.
Absolutely. I mean, there's been so much great work that has really gone into compliance and ocular surface disease and the success of the glaucoma treatment really being closely linked to that. So the number one really thing that is huge for us to kind of recognize is that, I mean, there's so much education that we've learned about how important it is to really pay attention to ocular surface and treat it at a high level. So those patients, as I kind of mentioned in the lecture, trying to keep our patients on the earlier stages of the continuum of glaucoma and the severity level of dry eye disease, really at the standard of care now is not to just supplement the tear film. We have an understanding that it's an inflammatory problem, that there is oftentimes an inflammatory and obstructive obstruction problems that need to be treated simultaneously. So needing to use kind of higher level treatments really should be the standard of care on a patient that we know is in need of chronic treatment and may, despite our best efforts, need to have a trabeculectomy at some point. So really co-managing things with our ophthalmology colleagues is so important. And that level of communication back and forth with an ophthalmologist who is treating glaucoma at a very high level, or a surgeon, if we, glaucoma is a really tough thing to manage just by itself. So if you know that you are not going to be doing IPL and probing and expression of the glands on your glaucoma patients, really handing that patient off to an ocular surface disease specialist is so critical for their glaucoma success.
Yeah, and that could be an optometrist within your community that you have a relationship, or an ophthalmologist. Yeah, and I love that you brought that up. Ahmad, can't thank you enough for being a part of this. Thanks for being part of Eyes on Glaucoma. Amazing, fun lecture to do with you, and just sure appreciate our friendship and your time today. Thanks for being here.
Love it. Thanks so much, Justin. I really appreciate it.